Good afternoon, Mr. Chairman. Good afternoon, dear audience. And for the sake of time, as Mr. Chairman said, I'm going to be brief. I'm just going to introduce my case to be a background for the discussion. Okay, and it's a STEMI case, ST elevation myocardial infarction in a young individual. Our patient is a 30-year-old male who has no history of diabetes, hypertension, or any cardiac or chronic disease before. He presented to our ER in Asyut University Hospital with typical chest pain of 1 day duration with maximum intensity of 6 hours before the admission. The patient underwent ECG. Like Mr. Chairman said moments before, we usually see young patients with myocardial infarctions. It's not uncommon anymore in Egypt. This was his ECG. There is a significant ST elevation in the inferior lead with reciprocal depression in the anterior leads, which is a typical picture of an inferior MI case. So that's why we just took him from the ER to the cath lab directly for a primary PCI. So we are going to, when we went to PCI, I'm going to show you the angiographic views of the patient. But first of all, we did echocardiography because this patient was young and the circumstances was allowing us to do an echocardiography. When you have done echocardiography, there was hypokinesia in inferior and infralateral walls, which is again consistent with the case of myocardial infarction, inferior myocardial infarction. But we saw a query mass related to the right atrium, measuring about 6 centimeters by 5.5 centimeters, and another mass anterior to the aorta measuring about 5 centimeters too. This is echocardiography of the patient. Here you can identify the mass related to the right atrium, compressing the right atrium. And the other mass compressing the aorta. Okay. Our decision was to just go for primary PCI, which showed huge LED aneurysm. Okay. We couldn't, unfortunately, you couldn't visualize the RCA after using many types of catheters. We used a big tail to do a non-selective angiography in order to identify the RCA, but we couldn't. Here you can see the huge aneurysm from the LED, and the underlying coronary territories are rather normal. This is the aneurysm in the left system. And this is a big tail. We tried to visualize the RCA, but we couldn't. So we decided to do a CT coronary angiography to visualize the right coronary artery. And that was the photographs of the CT coronary angiography. Here you can identify the left main, which is okay, and then the LED was huge. I don't know whether there is a here.
Yes, باينة.
Okay.
It's
another view is the LED with a huge aneurysm. Okay, and that's the LCX with no significant lesions. Slightly compressed by the aneurysm, but with no significant lesions. And that's the RCA. First of all, it arises from the left coronary cusp. That's why we couldn't visualize it. And we have identified a huge aneurysm in which there is a thrombus within the aneurysm. And that's why the patient presented with an inferior myocardial infarction.
This is amazing.
Okay. In order to diagnose the patient, we decided to do an aortography in order to see the aorta. And we have done aortography. CT aortography alongside with the CT coronary angiography. Don't know why it's not.
طب ما نشوف هو عمل ايه. كمل.
And that's the orthography. There is nothing very special in the orthography besides the aneurysm. But the aorta was fine, the iliac artery was fine, the femoral artery was fine. There is nothing to be identified rather than the huge aneurysms as you can see. And that faced us with a question. What is the diagnosis of such case? He is a young male patient with no risk factors, presented with inferior myocardial infarctions in his early 30s. So what's the diagnosis?
لا خليه بس يكمل عشان هو عنده وقت يخلصه ونتكلم في الاخر. بليز كمل بسرعه. You have 2 minutes.
Our investigation, we put in our mind that it could be a collagen disease, could be a vasculitis. This huge aneurysm is only identified in a vasculitis case. So we did all our workup for collagen disease, including anti-nuclear antibody, anti-double-strand DNA, and they were negative. CT chest and abdominal ultrasound were normal. The ESR and C-reactive protein were slightly elevated. Okay. So we consulted our colleagues in the rheumatology department.
Something congenital.
طب
We are going to
معلش عشان نخليه يكمل.
we are going to
لحسن نسال سؤالي هو يكون هيجاوب عليه والوقت مزنوق. I'm sorry بس عشان احنا مضغوطين بالوقت.
I'm going to do a case wrap up after
شو بقى عشان الوقت بيجري بس.
Yes, and I'm open to discussion if anyone has any question.
اوكي. خلصها.
Then that's what we do, and we started a steroid therapy because we diagnosed this case as Kawasaki vasculitis. And we gave the patient antithrombotic treatment besides the steroid therapy, and the patient significantly improved. Okay, the patient then underwent CABG, coronary artery bypass grafting, with saphenous vein grafts to the right coronary artery, and the patient was well and good after.
خلاص.
Okay, thank you.
كومنتس بقى. دكتور احمد كامل كان عنده سؤال معلش انا.
يعني هو عمل كابتشن ارسي يعمل بين على الارسي. هو ده اللي كان برضه
والال اي دي انا صحيح كلام حضرتك.
هل عملوا لايجيشن؟
عملنا كابش للال اي دي ارسي بس انا
ما كانش عنده سيجنيفيكيشن دي جاست انيوريزم. لو حطيت ليه مع ال ال دي عنده
تمام هو
هيحصل لايجيشن فوق والعيان ده اكشوالي المفترض المفترض العيان ده لو عنده بيتا ال دي انيوريزم ان انا اعمل له جراف ستاند.
هو اكشولي يعني الانيوريزم كبير قوي مفيش ستنت.
جراف ستاند مالهاش علاقه بالسايز بتاع الانيوريزم. جراف ستاند دي ستنتوم مصممه معموله على
to exclude this then
معموله عشان تبايباس اريا، يا اما تقفل البرفوريشن يا اما لو حطيتها انت مش محتاج انك انت توبتمايز اسمها الجراف ستنت دي معموله او ديزاين هي ممكن تبقى مثلا تفتحها كويس وانت عندك بدايه الانيوريزم. هي الانيوريزم انها تبقى زي تثبيت مع الانيوريزم، بعد كده الانيوريزم هيبقى زي ما الدكتور احمد بيقول الانيوريزم هتبوظ. انما انت هتحط جراس هتحط ليمه على بيتا ال دي.
ما هو انا هقول لحضرتك هو بس زميلنا الجراح اللي كان عمل العمليه دي سافر بره مصر.
يا فندم؟
سافر بره مصر، فانا حاولت اوصل له يعني عشان اخد منه
هو اصل فيه
طبعا
الماس اللي في الرايت اتريوم، الماس الكبيره اللي في الرايت اتريوم دول الانيوريزم. طيب احنا دلوقتي زي الدكتور عمارة ما قال انت you have an aneurysm in a young age. What are the possibilities? يا اما vasculitis يا atherosclerotic. In a younger age it's most likely to be some sort of vasculitis. No, perhaps Kawasaki. Yes, it's not common here. Like semi Kawasaki, pseudo Kawasaki. Like it's the same concept. انت دلوقتي you put a lima. Did he do anything for the aneurysm?
Yes, he has done an aneurysmectomy
للاثنين.
to the LED and to the RCA, and he had put grafts up.
تمام تمام. My point بقى, this is my point. My point is الاتيولوجي اللي جاب الانيوريزم ما اختفاش. ما اختفاش. وبالتالي يعني هو البرزنتيشن of an infarction is secondary to the primary problem اللي هو الانيوريزم. الability to form huge aneurysms inherent somehow في الفاسلز دي, هو عنده قدرة انه يعمل aneurysms كبيرة.
And that's why we have defined this case, or diagnosed this case as a Kawasaki vasculitis, because it only took the coronary arteries.
Yes, my point. Yes, my point is, إنه it is very possible إن he will come back with another aneurysm في حتة تانية.
Yes.
ما هو هتقولي طب ما احنا في الحالة دي هنعمل ايه؟ Yes, we need to close it, لأنه otherwise احنا عارفين الداتا. لو قرينا في الكتب والمجلات what is the natural history of coronary artery aneurysms, هتلاقي في الآخر مكتوب ايه؟ The natural history is related to the natural history of the underlying coronary lesion, not the aneurysm. However, this applies to atherosclerotic aneurysms, not الأحجام دي. لأن الأحجام دي are much bigger, وزي ما شفنا طبعا دي embolus من الأنيوريزم. This is not atherosclerotic obstructive lesion.
And that's the point of this case in such session, is to point that there is other causes than type
Yes.
I in young age. We should keep in mind that there is other causes like vasculitis, like Myocardial with its other differential diagnosis, and that's a point we are going to clear.
Very, very good point. Very exciting case. Thank you very much. And now we'll move on.
عملنا حاله طفل برضه جوازات كده وماشي الطفل على ستيرويدز لمعلوماتك. قلت له ليه هو الديزيز بيقف تاخد تريتمنت ستيرويدز وانتي انفلاماتوري كتير يعني
كتير بيقفوا. They don't redevelop and we hope ان ده ينطبق هنا برضه ان شاء الله. Thank you. This is very important for us to know. Now it gives me a great deal of pleasure to introduce my dear friend, Professor Ahmed Omar al-Manufiyya, to give us his presentation on pathophysiology and mechanisms of coronary vasculitis. Continuation, كأنه عارف الحالة.
بسم الله الرحمن الرحيم. طبعا احنا يعني الحاله انترستنج كيس اللي احنا شفناها من شويه، وطبعا البرزنتيشنز القادمه كلها بتدور حول في الفلك القصه بتاعت الحاله اللي شفناها من شويه. انا هتكلم عن جزئيه معينه فيها الباثوفيسيولوجي ميكانيزمز كوروناري فاسكولايتس. What's vasculitis? Vasculitis means inflammation of blood vessel wall. It affects arteries, veins, even the capillaries, so it is not limited to the arteries per se. What are the potential causes of this inflammation? Vasculitis may be caused by either immunologic hypersensitivity reaction or diet invasion of the vessel by various microorganisms. The immunologic hypersensitivity reaction may be complement mediated, this is referred to as type 2, or cell mediated, referred to as type 4, or both complement and cell mediated. This is referred to as immune complex mediated, which is responsible for most cases of vasculitis. Or by diet invasion of the microorganisms, various microorganisms like rickettsia, fungi, even meningococcus can reduce endotoxins that directly attack the vessel causing vasculitis. The immunologic mechanisms causing vasculitis, the immune complex position is responsible for most cases. It's a response for most cases of vasculitis, and it starts when an allergen attacks the body. So the immune system or the body responds to this allergen by formation of what's called immune complex. This immune complex triggers the release of series of proteins from the liver called complements that's activated in a specific cascade. When activated, especially the complement type A, it attracts neutrophils. The activated neutrophils directly attack the vessel, the endothelium or the vessel wall, causing fibronecrosis, and consequently, this fibronecrosis may result in either thrombosis or weakness of the wall causing aneurysm.
So, the immune complex deposition results in eventually results in either thrombosis causing infarction or weakness of the wall causing aneurysm. The most common in this immune complex deposition mediated vasculitis is henochinorin perbra. The type 4 hypersensitivity, which is the late type of hypersensitivity, and allergen attacks the immune system. Few days or weeks, the division may develop element of vasculitis, and is diagnosed pathologically by detection of granulomas, which are collections of immune cells detected under microscope. The most common example is the temporal arthritis. The diet invasion by different pathogens, like calcium and fungi, or fungi that produce endotoxins that attack the vessel wall, causing vasculitis. How to diagnose vasculitis? Vasculitis may be diagnosed laboratory by detection of anti-neutrophil cytoplasmic antibodies. This is the ANCA, or by ESR that's elevated in various types of vasculitis. The anti-neutrophil cytoplasmic antibodies, these are antibodies produced by neutrophils. Actually, when the allergen attacks the neutrophils, the neutrophils breaks down this allergen and produce antigen. This antigen presented on the cell surface of the neutrophil. The activated B lymphocytes responds by formation of antibody against this antigen. These are the anti-neutrophil cytoplasmic antibodies, or the ANCAs. The ANCA correlate with the disease severity. The higher the titer, the more the active disease, and is detected by immunofluorescence. There are two types of ANCAs, C ANCA or P ANCA. Cytoplasm C ANCA and perinuclear P ANCA. Cytoplasm, the diet neutrophils leaves remnants. These remnants are either cytoplasmic or perinuclear. The cytoplasmic spot called the proteinase 3. Antibodies directed against this proteinase 3 is the cytoplasmic C ANCAs, and myeloperoxidase. This is perinuclear P ANCAs. So the antibodies directed against myeloperoxidase called perinuclear or P ANCAs. An example of cytoplasmic C ANCAs, Wagner granulomatosis, and the P ANCAs, an example, Seychelles-Strauss syndrome and polyarthritis nodosa. Classification of vasculitis based on the vessel size. The vasculitis may be large vessel vasculitis, giant cell arthritis, Takayasu, and medium vessel vasculitis. These are vasculitis affecting the coronaries, like polyarthritis nodosa, Kawasaki, thromboangiitis obliterans. Small vessel vasculitis affecting the small vessels and the capillaries, like henochinoid perbra, Seychelles-Strauss syndrome, Wagner granulomatosis. We are caring about the vasculitis affecting the medium-sized arteries because these affect the coronaries. Clinical manifestations of vasculitis. The clinical picture of vasculitis usually depends on the size and extent of the vessel involved. Large vessel vasculitis usually presents cause thrombosis, so the patient may present with lost pulse or cerebral stroke. Medium vessel vasculitis affecting the coronaries, so the patient may present with myocardial infarction or coronary aneurysm. Small vessel vasculitis affecting the small vessels and the capillary, so the patient may present with perbra. General features associated with various types of vasculitis: fever with loss, malaise, myalgia. The most common types of vasculitis: polyarthritis nodosa. We are caring about this type of vasculitis because it mainly affects the coronaries. It affects the small and medium-sized muscular arteries, typically involves kidney, heart, liver, GIT, and scan. For unknown etiology, it spells the lung. Usually associated with hepatitis B, antigenemia, or hypersensitivity to IV drugs like IV amphetamines, and is mediated by type 3 hypersensitivity immune complex deposition. So in polyarthritis nodosa, it involves small, medium-sized arteries with immune complex deposition, activate complement system, initiate inflammation, causing damage of the vessel wall, neutrophil infiltration, and then fibronecrosis causing either thrombosis or aneurysm. This is a picture of fibronecrosis seen under microscope. This is a picture of segmental fibronecrosis. The polyarthritis nodosa, it involves the entire layers the entire layers of the artery. This is that's serious. It may involve part of the whole circumference of the artery or part of it, and results in fibrinolysis. Consequently, results in either thrombosis causing infarction or weakening of the vessel causing aneurysm in the kidney, heart, and GIT. Clinical features associated with polyarterial stenosis are more common in young to middle-aged men. Signs and symptoms usually due to ischemic damage in the target organs, kidneys, vasculitis causing infarction, kidney infarction leading to hypertension, hematuria, albuminuria, and GIT, bowel infarction causing tunnel vein melena, skin, ischemic ulcers in use, coronary arteries, cause aneurysm or myocardial infarction. Systemic manifestations associated with fever, malaise, with loss. Because of this, usually renal failure, because kidney affection usually precedes coronary affection. Diagnosis laboratory by detection hepatitis B substances associated in 30% of cases, hematuria and RBCs caused. Laboratory test the ANCA. In these cases, almost fatal if untreated. However, it give good response to immunosuppressive therapy if treated. Example of custom vasculitis, classic cases of vasculitis. The classic case of vasculitis يعني vasculitis ما بنغلطش فيها. 4 years a child presented with fever, redness, eyes, redness of the eye, oral cavity, swollen hands and feet, rash over the trunk and extremities, peeling of the skin, and usually associated with cervical lymphadenopathy. Presented with chest pain, ECG changes consistent with myocardial ischemia, diagnosed as Kawasaki or mucocutaneous lymph node syndrome. Kawasaki, also known as mucocutaneous lymph node syndrome, this is acute self-limited febrile illness of infants and children. It's one of the manifestations of vasculitis affecting the coronaries. So Kawasaki is a childhood vasculitis that mainly target the coronary arteries. Coronary artery involvement can lead to coronary thrombosis or aneurysm formation or its rupture. This is a picture of coronary aneurysm as artery aneurysm in a child. So our case, this is young patients about 30 years of age, presented with myocardial infarction. It's not associated with atherosclerotic risk factors, not known to be diabetic, nor hypertensive. It's presented with inferior function. This should be our attention to other etiology rather than the usual atherosclerotic changes or atherosclerotic disease. We should pay attention for young patients presented with ischemic manifestations. This young guy presented with chest pain, common with ECG changes consistent with acute coronary syndrome, like ST segment elevation or depression. We should pay the attention as whether this guy associated with atherosclerotic symptoms or inflammatory symptom. Inflammatory symptom, many cases as you are faced. We are faced and diagnosed as ischemic, where and you are proceeded to coronary angio, may eventually diagnosed as element of vasculitis. أنا شخصيا يمكن أصغر عيان عملت له قسطرة في حياتي كان بنت سنها 16 سنة. أذكر إنها كان جاية لي بشيستين، باباها جايبها مع عاملة كاردياك انزيمز تحاليلها عالية جدا. لدرجة إن في ساعتين عملت لها التحاليل دي في معملين، طلعت الأرقام عالية جدا. ST segment elevated typical anteroseptal myocardial infarction. raised ST segment من في واحد حد في 4. والبنت دي أنا عملت لها أنجيو غصب يعني أنا يمكن ما كانش قدامي حل غير كده، وطلعت نومة كورونري. أخويا أستاذ بطنة كلمته ساعتها قلت له الوضع كذا كذا كذا. البنت دي طلعت في النهاية سيستميك لوبس والميوكارديال انفاركشن في الغالب كان انفلونزا. احنا بنقابل حالات كتير كورونا انيوريزم، دي حاجه كومن جدا اثناء الانجيو. ساعات بنتوقع ان ده جزء من اسوسكوبيك ديزيز، بس ما فيش ما يمنع. انا عملت من حوالي 4 أو 5 سنين انجيو مش هقول بنت بقى، هي زميلتي اللي كان سنتي في الفصل وانا في ابتدائي، كان سنها وقتها 49 سنة، عندها هيوج ال دي انيوريزم. بعد ال دي اسمه انيوريزم سي 2 ال انيوريزم سبروكسيمال ال سي اكس انيوريزم ديستال ال 6. انا مش عملت لها اللي دي وحطيت لها 3 ستات. هل السؤال بيطرح نفسه، هل الانيوريزمات كانت اسوسكوتيك ديسيز وده كان كويس؟ اعتقد ان في حالات كتير ممكن تعدي علينا وهي لها ايتيولوجي.
هي كان سنها كبير مش كده؟
49 سنه.
كم؟
49 سنه.
49 سنه. It's still premature coronary disease. بس السي تي او معناها انها she developed disease من على الاقل 3 اشهر الشريان ده قفل.
اكيد بس وجود الانيوريزم عندها هيوج انيوريزم بروكسيمال ال دي بعد قبل السي تي او، وكان عندها بروكسيمال انيوريزم في السي اكس، وقدام طلع فيريفيكيشن طلع لها انيوريزم في السي اكس.
I would probably assume ان this is more likely atherosclerotic عن vasculitis لانه كان هيبتدي I think بدري عن كده وكان manifest probably earlier than this.
Thank you.
We don't do. Thank you very much. هل في أي أسئلة؟ Any burning questions? Systemic lupus. Lupus. هو يمكن الحاجة اللي reassuring إن الفاسكولايتس once they're treated they كأن في فترة هيجان وبعدين بتهدى regarding coronaries. Now I'm very happy to present Professor Amal رزق من جامعة القاهرة، وحدة دكتور شريف مختار will give us her presentation on the advances what we really need to know. And I really think هو ده القصة هنا. Advances in genetic testing for identifying individuals at risk for coronary aneurysms.
Good afternoon. طبعا احنا هنروح لموضوع تاني خالص يمكن ما بيبقاش في ذهننا. زي ما قال دكتور أيمن, we have to have something in our mind to search for it. This is the first thing that you should know. What are the advances in genetic testing for identifying the individuals at risk of coronary aneurysm? As we know, coronary artery aneurysms is seen in 0.3% to 5% in patients undergoing coronary angiography, as mentioned before. The giant aneurysm have a prevalence of 0.02% to 2%. A localized luminal dilatation measures 1.3 to 2 times the diameter of a normal adjacent reference segment, whereas the giant aneurysm is more than 20 millimeter to 40 milliliter, or 4 times the reference vessel diameter. What are the etiology? As we mentioned before, so many etiologies, but the most important of which atherosclerosis, Takayasu arthritis, Kawasaki disease, and the connective tissue syndrome, and recently the secondary to percutaneous intervention, angioplasty, atherectomy, and stenting. We are going to focus light upon the most important causes that are contributing for coronary artery aneurysm. In all conditions, there is a disruption of the intima and media. There is an inherent defect in the vessel wall that can predispose atherosclerosis to aneurysm formation. What happens that the media is weakened in areas of marked atherosclerosis with a decrease in the elasticity, decrease of the stress intolerance of the intraluminal pressure, leading to dilatation of the vessel. During percutaneous intervention, there is delayed re-endothelialization, hypersensitivity reaction, residual non-healing dissection, and high-pressure balloon inflammation. Coronary artery aneurysm are classified according to shape into saccular and fusiform, according to vascular wall integrity, into true and false aneurysm or pseudoaneurysm. According to topographical extent, there is 4 types. Type 1, diffuse dilatation of 2 or 3 vessels. Type 2, diffuse dilatation in one vessel and localized in another. Type 3, diffuse dilatation of only one vessel. Type 4, it's a localized or segmental dilatation. Atherosclerosis has been linked to 50% of the artery algorithm in adults. The histological examination reveals hyalinization and lipid deposition leading to disturbance of the intima and medial layer of the vessel and destruction of muscular elastic component, leading to weakness and aneurysm formation. The gene-wide association study discovered an association of variants on the chromosome 9, P21.3, with coronary artery disease. The most important disease, which is Kawasaki disease, this is the most common cause of coronary aneurysm in childhood, and the second common cause in adults. It's an acute inflammatory syndrome that results in acute vasculitis of coronary artery, leading to subsequent coronary dilatation and end up into coronary aneurysm. What is the genetic contribution? This is the most important. According to the genome-wide association study, they have contributed to the recent identification of various gene loci, not only to identify the Kawasaki disease patient at high risk of coronary artery aneurysm development, but also, which is very important, to recognize the extent and severity of their vasculitis to help and initiate the early diagnosis and robust treatment. Researchers revealed association of genetic variant, which is RS2833-195, in the intron of the TYAM1 gene, with the development and severity of coronary aneurysm in Kawasaki disease. The TYAM protein plays a role in the chemokine-induced T-cell migration and infiltration of the lymphocytes into the vascular wall during acute vasculitis stage of Kawasaki disease. Not only this, but during Kawasaki disease, very important things occur and lead to coronary artery aneurysm. The matrix metalloproteinases, they are enzymes that can degrade connective tissue protein, leading to a weakened vascular wall, and the metalloproteinase expression is regulated by the prostaglandin E2 cyclic AMP pathway. During Kawasaki disease, there is an inflammatory cytokines which can stimulate this pathway, leading to an imbalance in the level of the metalloproteinases. Tissue-specific inhibitors for metalloproteinases, tissue inhibitor 1, 2, 3, and 4, are secreted by the smooth muscle and can regulate the increased activity of the metalloproteinases. In coronary artery aneurysm, there is an imbalance between the activators and the inhibitors, and there is increased level of matrix metalloproteinases and decreased level of the tissue inhibitors, leading to a drive and degradation of vessel wall matrix and aneurysm formation. Also, genetic polymorphism of the metalloproteinase 9 gene is associated with coronary artery aneurysm in Kawasaki disease. What about the connective tissue disorders? Marfan syndrome is a very well-known disease that is also contributing, or there is also with it a pathological variant which is called fibrillin gene. This is a very important gene. Marfan is associated with mutation of the fibrillin gene. What does this gene do? The fibrillin is a very important element for microfibrils that surround the elastic fibers for maintaining the vessel wall integrity. Fibrillin gene is homologous to the family of the latent transforming growth factor beta binding proteins, which maintains this beta protein in an inactive complex. What happens? That there is a mutation of this gene, which leads to overactivity of the transforming growth factor beta, and through mechanism of cystic medial necrosis, contribute to the formation of coronary artery aneurysm. Mutation in this gene leads to overactivity of the transforming growth factor beta. And this mutation leads also of transforming the growth factor beta receptor. It has been found associated with aneurysm. So this fibrillin gene mutation is very important also for formation of coronary artery aneurysm in connective tissue disorder. Also, Louis-Diaz syndrome is also associated with the transforming growth factor and liability for coronary artery aneurysm formation. All these are genes that are associated with coronary artery disease and aortic disease in general. As you can see, the fibrillin gene in the beginning and the transforming growth beta signaling with all the types of transforming growth factor receptor 1 and 2 with SMAD 3 and 4 and the smooth muscle cell contraction, ACTA2, myosin heavy chain, myosin light chain, pyruvate kinase 1, and others. It doesn't look, this is the signaling of transforming growth factor that there is a loss of function for the variants that causes coronary aneurysm. I'm sorry, it doesn't. And for the vascular smooth muscle, as you can see, there is myosin light and heavy chain together with the fibrillin gene that is down. It's mutated, and so the elastic tissue and fibrillin is not in a good form and lead to formation of aneurysm. This is the ACTA2 mutations, and it is a very strong variant that predisposed to heritable thoracic aortic disease. Other panel that is present, as you can see, there are many, but the most important of them are transforming growth factor, ACTA2, myosin heavy chain, collagen type 2, alpha 1 chain. The SMAD family, the mutation in this gene are associated with increased risk of thoracic aortic aneurysm and dissection. The fibrillin gene that we mentioned with connective tissue disorder, and there is a soluble carrier family 2 member, TEN and ACTA. A mutation in this gene has been associated with coronary artery aneurysm and may contribute to an increased risk of aneurysm in general. Other group are myosin light chain and Adams 10, which are the metalloproteinases that we mentioned before with Kawasaki disease, and the transforming growth factor beta 2. This regulation leads to aneurysm formation. And these are two present, the recently present. What is the importance of genetic testing? هل كل الناس هنعمل لهم genetic testing؟ بالطبع لا. We have, it's important because it can help us and help other family members to understand their genetic risk. It helps to identify at-risk family member for aneurysm and also help to early diagnosis, early treatment, better outcome by identifying the specific gene variant responsible for the aneurysm. Who should be considered? طبعا لازم يكون في family history, the number one. Those who are subject of having hereditary connective tissue disorder, they are always associated with the predisposition to aneurysm. Those who have 2 or more relatives who have had coronary artery aneurysm or dissection at any age, and those who had several aneurysmal disorders, and those who had an aneurysmal disorder at a young age. So in conclusion, as we mentioned, the coronary artery aneurysm are usually associated with atherosclerosis and commonly thought to be the cause by the main cause, which is atherosclerosis. In still other cases, atherosclerosis may cause aneurysm. And 3, these genetic defects include excessive active transforming growth factor beta, dysfunctional growth factor beta binding proteins, overactive matrix metalloproteinases or loss of function mutations in inhibitors of the matrix metalloproteinases, and recent advancement in genetic testing have significantly enhanced our ability to identify individuals at risk for coronary aneurysm. The genetic screening method dives into the intricate molecular landscape implicated in coronary aneurysm development, offering valuable insights into an individual's predisposition to this cardiovascular condition. By examining variations with these genes, clinicians can identify the potential genetic markers linked to coronary aneurysm susceptibility, allowing for personalized risk assessment and early intervention. as we continue to unravel the genetic basis of coronary aneurysm, the integration of cutting edges test holds a promise in revolutionizing preventive strategies and optimizing patient care. Further studies are recommended for the discovery of more variants for identifying individuals at risk of coronary artery disease. Thank you.
Thank you very much for this very enlightening, in-depth analysis of a complex issue. Questions?
I would like to challenge the diagnosis made as a Kawasaki. Usually Kawasaki, as it has been described by Dr. Ahmed, it has a very specific and a very dramatic clinical picture. It is usually during the childhood, there is febrile illness, conjunctivitis, lymphadenopathy, which is actually, there is no any data about this childhood disease. The question is, could genetics by itself, in the absence of any other pathogenesis, could induce such like huge aneurysms? And the question also is there any specific morphology or shapes for the aneurysms developed in the context of genetic susceptibility rather than vasculitis؟ يعني انا اقدر من الانجيو اقول دي mostly genetic mostly vasculitis.
هو بيبقى فيه contribution في حالات معينة إن يبقى فيه genetic superimposition على الواحد. يس احنا لسه بنعمل يعني دلوقتي هو لسه الناس كلها investigating. No one يعني you cannot be sure 100% but at least the patient of the family مثلا جاله aneurysm and nobody knows the variant. ما حدش عارف ان هو مات عشان خاطر كان عنده genetic. Okay, this person لو حصل في 2 او more family كل الفاميلي لازم تبقى screen لانه most probably the reason will be genetic from the beginning. And this is the point إنه who to select to make the genetic study to be sure what is the origin of the disease. Is it the disease itself, vasculitis only, or it's genetic primarily and end up into the aneurysm. All the studies are done for this. على فكرة الفاريانتس دي كلها it is done already. يعني البانل ده كله ممكن يتعمل all over ويبان فيهم which variant. لو أنا مش عارفة إن البيشنت ده كان عنده ايه يعني جاله انيوريزم بسبب انهي فيريانت، لكن لو عارفه ان هو جاله فيريانت معين we ask for the only variant that we are يعني searching for and to detect the rest of the family because most of the diseases have a genetic origin. بس عشان الليميتيشن for the cost والديسكفري بتاعت كل شويه فيريانتس ده اللي بيخلي الامور مش ماشيه بنفس الطريقه زي ما بنطلب لابوراتوري انفستيجيشن. لكن definitely this will be the future. يعني this will be really always we are attributing disease that we don't know the reason that it is most probably due to genetic condition. فاحنا لسه يعني كل ده going on and وكل شويه بيطلعوا variants. يعني هما مش مثلا واحد وخلاص واكتفينا، كل شويه بيلاقوا فيرينت على كروموزوم تاني. حتى حاليا دلوقتي على كروموزوم 20 ابتدوا يدوروا في فيرينتس وهيطلعوا بعد شويه الستادي دي ريست عليه.
Okay, I would just like to ask you a quick question. For which people probably would you recommend to do some testing؟ هل مثلا العيانين دول الفاميلي relatives يعني في عيانين معينين الفيرست جنريشن؟
first relative طبعا الناس اللي عندهم connective tissue disorder the whole family لانه بيبقى يعني very good number يعني can be affected. لكن لو كوازاكي او one of these diseases at least the first relative because definitely واحد منهم لازم يكون عنده.
Which raises the question دكتور الحالة اللي قدمتها هل سألتوا الفاميلي في حد كان عنده حاجة؟
بالظبط.
كان في أي حد عنده؟ لا الفاميلي.
Most probably.
That's my point.
Yeah, most probably that he can die suddenly. Okay, يعني you should never know always that this is the end.
You should ask for history of sudden death in the family.
At young age if something happened at
This
young
is
age,
important.
yes.
Maybe you should ask about history of sudden death in the family.
Sometimes you don't know
Young
this
age.
except at autopsy. يعني,
Okay.
You understand? It's not something يعني. Excuse me? Now we are dealing with الحقيقة in Egypt حكاية ال DNA sequencing to provide the best حقيقة يعني the best results. You don't have an institute to do this. يعني it is done on individual basis and this doesn't give the results. But now we are having a connection with a CAP accredited laboratory in Dubai, and that is doing this very easily, and the whole panel is done.
But
After we detect find the gene, if there is anything else to be treated, gene therapy or isolation of the gene, what are you going to do?
At least you know that one or two or three of the family. You can prevent from the beginning. A style life, different style life, a different way and for inflammation or vasculitis, you are expecting.
you can monitor the patients for early diagnosis and management before they come. They present with sudden death or event.
I cannot prevent.
No, you can monitor to be able to perhaps prevent sudden death or an acute coronary event.
By gene therapy or isolation?
No,
No, not yet.
Not yet.
Therapy, not yet. But at least, for example, or what we are doing now, the campaign or awareness of everything. What for? It's just to prevent the symptomatology or to prevent the disease to come. And at least you are going to focus light on the screening of the family, that this doesn't occur repeatedly.
Thank you very much.
Welcome.
We'll move on to the next presentation. Professor Shalak Berzingi from the USA. Welcome to Egypt, and we're looking forward to your insightful presentation, which is titled Interventional Approaches for Coronary Aneurysms.
Mr. Chairman, Azizi Dr. Ayman, distinguished faculty, ladies and gentlemen, it's my honor to be here to participate. Mr. Chairman, Azizi Dr. Ayman, distinguished faculty, ladies and gentlemen, it's my honor to be here to learn from all of you and to share my knowledge. This is to address the subject. That's how much it's written in the 2021 ACC AHA SKY guideline for coronary artery revascularization in coronary artery aneurysm. And that's the problem and the dilemma that we have, how to deal with these patients. We really don't have randomized trials. We don't have large sets of data. We don't have set guidelines to enlighten us as what's the best approach to manage these patients. So we are in limbo. So this is a coronary angiogram that was sent to me in 2016 by a colleague of mine, and he's actually a very dear friend to me. He's an ENT surgeon. And he had epigastric pain, and he was in his office. The cardiologist was next to him. Because he was a cardiologist, he made the correlation, maybe coronary artery disease related. He ordered some labs, including troponins, which was strongly positive. So then he underwent a heart catheterization. You can see from the right coronary artery, ectatic lesions, some mid-RCA lesion, and the LAD aneurysmal, some mid-distal LAD disease. This is another view, and this is the circumflex. So this angiogram was sent to me, and I reviewed the angiogram and I shared it with my colleagues at WVU. And then at the same time, Dr. Al-Kuli joined us from Mayo Clinic. So I told him, this is a very dear friend to me. Would you mind showing to Dr. David Holmes at Mayo to see what's his opinion, what should be the best strategy here? So he came back, he said, this is an excellent question for a state-of-the-art review. If the cardiologist doesn't know what to do, you don't know, you take it from one team to the next. Let's correct what data we have. And our two fellows, Akram Kausara and Fahad Al-Qahtani, I think Fahad, what's his name listed in this conference? He's in King Fahd I believe, hospital in Saudi Arabia now. He was a fellow with us at the time. He completed his training, along with Dr. Al-Kuli, others, made an excellent state-of-the-art review of whatever was available, and it was published. We started the work on it in 2017, and it was published in 2018, and it was the most read article of JACC in 2018. Many, many citations and reviews. That all sheds the light as what the problem we have with these coronary artery aneurysms, how to manage them, what's the best approach. We really don't have large sets of data. And that's the main problem. So one of the central illustration in the paper, which I'll go some part of it here, the coronary artery aneurysm, as mentioned, it could be saccular, it could be fusiform, it could be focal in one vessel, one segment, it could be diffusely multiple branches of multiple arteries. The presentation can be asymptomatic for the most of the time, or it can present with an ACS, or it can present with thrombus formation in the aneurysm with some subsequent symptomatology associated with that. And occasionally, not uncommonly, the aneurysms can be associated with stenosis. And this is because almost 50% of the time that associate with coronary atherosclerosis, so there could be stenosis one or more. So that's why they may present with angina. So it could be effort angina, it could be asymptomatic, it could be an ACS presentation, or thrombus formation in an aneurysm. And as it was mentioned here, actually, sometimes the presentation can be sudden death. And even if they present sometimes with an uncomplicated aneurysm that we can diagnose, or it can be complicated aneurysm, particularly when it gets ruptured, it can be a catastrophe with a sudden death, or if, in the best case scenario, you might see a patient with cardiac tamponade and, you know, big emergency. The etiologies behind aneurysms, as it was mentioned, elaborately discussed here, could be Kawasaki disease, especially in the younger people, or any vasculitic process that can disrupt the intima and media. And normally it's a muscular artery. The coronary arteries are muscular arteries. You have a thin intima, and then internal elastic lamina, external elastic lamina. There's adventitia. The muscular layer, when it undergoes inflammation, it weakens with a lot of metalloproteinases and other factors. It can be replaced with fibroblasts, myofibroblasts, which cannot tolerate the shear pressure that comes from the coronary arterial circulation, and over time can lead to various aspects. How do we manage these cases? Well, a lot of it depends how do they present to us. When they present with a stable coronary artery disease, really we don't know, because the natural history, we diagnose them at the age of 43. What if I have seen this patient 15 years ago? What would I have done with him? So long-term outcomes and complications that comes with it, we know that if you follow them over the next 5 years, they are more likely to have ACSs. They are more likely to have other problems related to that. So that's why when they don't present with an ACS, it's really still a challenging treatment strategy to do. When they do present with an ACS, of course, if they present as STEMI, like anything else, really, you try to reestablish the flow back to the artery. The approaches to it, of course, PCI surgery, both of them are challenges associated with them. Challenges when they present, just imagine that same patient that you just presented came with a thrombus in that LAD. How do you get into the LAD to open the distal LAD? That giant aneurysm represents a big challenge. So one of the ways that you should think about these aneurysms, if you know them ahead of time, it's great. CT scans and many other angiograms having ahead of time, but they come to you with an acute MI, the most challenging thing is really to get good pictures. Sometimes you try to take a picture, you take the diagnostic catheter, the dye swirls, and you just can't see very well, is it all thrombus, is it just not too much flow? So may upsize the catheter, get a good picture, maybe a 5 French, 6 French, a guide catheter, and if you have an aneurysm early, which I can show with a case after this, that you can actually advance the guide and actually further advance it into the distal bed. And if you are dealing with an aneurysm in the proximal vessels, you also should modify the PCI procedure. As we call it sometimes in CTO, you kind of have a second base of operations. You take the guide catheter distal into the vessel, engage it very well, then advance maybe a guide liner into the aneurysm segment, then you take a microcatheter. You shape your wire very differently. Instead of having an F shape, you may use a D-shaped, or an L-shaped, much bigger curve on it, take a microcatheter, and if you can't find the distal bed, then you may choose to use an angled microcatheter, like Supercross has 90 degrees, bigger degrees, lower degrees. So a lot of times it's really challenging to find the distal bed of the artery in order to wire into the distal bed. Now, what approaches do we have? So the first thing is to reestablish flow. If you can establish a TIMI3 flow, everything else can be taken care of later. There is no rush in doing anything at the time. So there are various ways in interventional to approach these patients. So it was mentioned in this case that one of the strategies, for example, for that RCA, I don't know if you can go through all of these aneurysms and put multiple stent grafts that traverse through the entire length of this, but most of the time these aneurysms are not very long. So you may be able to pass the wire, and actually one way of managing is a stent graft. Graft master has been used for a long time. There are cases that have been demonstrated, they are OK series with relatively OK outcome, but they are associated with their challenges. They are a lot more likely to get stent thrombosis. And so for that reason, so that also has its own challenges. Now, there are case demonstrations that people have put a balloon across the area, and you actually can coil isolate the area of the obstruction, and that's one way to manage those. You basically, if you are not across a side branch, probably stent graft is the best strategy, especially if you see the entrance and the exit and they are not very far than stent grafts. But if you have side branch, you can wire into the side branch, and actually you can take a microcatheter and deploy the coils into the aneurysm segment and then stent across it. So that way you isolate and at the same time prevent any coil material clotting getting back into the main vessel. So this was one of the strategies that was mentioned. Of course, anticoagulation, antithrombotics are very essential. These patients are more likely to get into trouble from clotting. So these patients, typically we use a lot of, go ahead with ACT, use 2B3A inhibitors, and subsequently you keep dual antiplatelet agents. Surgically, they have their own challenges. I'm not going to go to details of the surgery, but most of the time, you open the culprit vessel, then you make a decision depending how much coexistence disease that we have. So CT scan is very helpful in these patients because it allows you not only to see the aneurysm, but actually what's around the aneurysm. So that allows you whether any mass effects, thrombus within the aneurysm, like in this case, you can see that there was aneurysm in the right, in the LAD with thrombus formation. So you can have a better treatment strategy. You don't have to go these cases acutely. You can let the antithrombotics do its effect. If they come with an acute MI and you can't open the vessel, thrombolysis is a good way of doing it. But if you can make a channel, even a TIMI1, TIMI2 flow, probably your thrombolytic might work better. So this is a case who presented with an acute myocardial infarction in the LAD. Of course, LAD was treated with a stent. TIMI3 flow was established. Again, there was slow flow, so a lot of times with these they require thrombectomy. We have a couple of cases that we used penumbra catheter. It's really angiojet. I have used it 7-8 years ago. You have to put a temporary pacer. It has a very good extraction, but penumbra with cataracts catheters really does a very good job in those. But that also could be complicated by slow flow, so you have to be prepared to give adenosine, nicardipine, which I find nipride probably works the best when you put it, and in resistant cases you could actually spill some epinephrine into the vessel. It has its own concentration that you have to guide by. So this particular case had also aneurysm in the right coronary artery. 4 years later, the stent in the LAD was patent, but a lot more disease developed in the LAD. Circumflex became tight when it wasn't tight, and the RCA was a lot more. So this is the initial angiogram on the left-hand side, and then the LAD was occluded, and of course work was done on that. And then it was wired, you know, stent placed, thrombectomy. And then on the right-hand side, you can see that the aneurysm grew much bigger in size 4 years later. And that's the challenge with these. You treat it at point A in time, you don't know what happens in 4 years. I mean, you treat it here, but this disease process is an ongoing. That's why it's a challenge. So this is another case. Distal right coronary artery had tight lesion. You can see it in panel A. And that was treated with a stent. However, the guide was deep. It was an Amplatz guide for some dissection. That dissection was treated with another stent in the proximal RCA. 8 years later, that's an acquired aneurysm. that the patient developed an aneurysm in the right coronary artery, and then the mid RCA was occluded. Probably a thrombus migrated south and occluded the right coronary artery. And then underwent PCI to the distal right coronary artery. Of course, the aneurysm here was easily traversed with a wire and underwent a graft master stent implantation with reasonable results on that. So this is the angiogram on the left with the initial PCI to the RCA and guide-induced dissection. And then the guide-induced dissection was treated with a stent. The distal RCA was treated, and then this is the subsequent PCI to the distal RCA and isolation of the aneurysm with a graft master. This is an LAD aneurysm. Also underwent PCI wiring to both the LAD and the DAG with coil isolation of the graft. So wire both vessels, and you pass a microcatheter into the aneurysm, and you deploy the coil, and then you stent across it to isolate it. If you put a stent graft, you don't use a stent graft here because you will be sacrificing two big branches. So not every anatomy is are treated similar. So these are some of the stent grafts that are available in US. This is another case that has big LAD aneurysm, came in with an acute MI, and the aneurysm was actually initially treated with a stent graft, the graft master, and at the end of the case had a good flow, and then 6 hours later thrombosed the stent. So the panel down 6 hours later came with LAD occluded right, and what happened to the stent? It migrated south. So this was actually a published case that I pulled. So the stent graft master migrated into, it's a saccular cell. So they had both edges, but because of the DAG, they couldn't come back too much proximal. They didn't want to sacrifice the branch, even though they went across it, but the stent was lost. So they were able to rewire through the stent graft and get to the distal bed, and then advanced a new stent, and basically stent within a stent, and basically treated the case. So this is the angiogram on the first time. After they placed the stent, you could see there was some flow going into that aneurysm, and that's why probably saddled, and then the stent graft on the left-hand side was occluded, and then, of course, recanalized after wire passing through. Luckily, I mean, you may not be able to repass it, but so this is what you do when you treat coronary aneurysm. Basically, you have to go and search what's out there. They're all case reports, case series, small numbers. We don't have. This case actually was referred to me. A lady in her late 40s, she had significant exertion-related shortness of breath and some exertion-related chest discomfort, so she was sent for a right and left heart cath. So I did the right and left heart cath, and this is the left coronary. You can see some flow from the RCA going to the left side, and then you get to the left side. This is the picture. So you can't even opacify the vessel, and huge aneurysm from left main extending throughout the circumflex, and then connected probably to the fistula into the venous system and draining into the somewhere on the right side, which seems to be to the right coronary sinus and right atrium. So again, this is challenging to take a good picture, but you can see that the LAD is actually seen beyond the area of the left main and bifurcation. So here advanced a guide, a large EB4 guide, so that you can actually traverse, and you could take a picture of the LAD. LAD was fine, and then you pull back and you take a better picture. Of course, this case, the QPQS was actually 1.4. There was significant shunting, not only, so sent for surgery, and the surgeon discussed it with our team, and the patient didn't want to go for surgery. He wanted to try occlusion, and here a CT scan is very important in this case. I cannot underestimate the value of CT scans in these cases. So the course was delineated and actually was brought to the cath lab, and both venous and arterial access, and a wire was passed through the venous side, and then retrieved, then a wire passed anti-grade and snared into the venous side, and an Amplatzer plug was deployed. The initial one didn't seal it, so it was changed for a different one. And finally, the angiogram showed basically still not complete occlusion. So this is a year and few months later, the patient was recommended to go for surgery. She has still not made the decision to go for surgery. But on the other hand side, we really don't know exactly what to tell her. What your natural progress would be. You treat them with antiplatelets, aspirin, statins, very important for inflammation of the wall, ACE inhibitors, again for the same pleiotropic effects, and we really don't have good answers. Dr. Ayman said, hopefully we find some good answers, but really still don't have very good answers. It's all case reports, small case series, and we still don't know exactly what the best treatment for these patients are. Thank you.
Thank you. Thank you, Dr. Brzezinski, for this wonderful presentation with many illustrative cases. I have a question. I know maybe I should ask it to Renu Vermani or Alok, but because it's really a pathological, the answer is from the pathology. From the cases of sudden death that are published, and she publishes a lot on sudden death. Obviously, all her patients are dead. What percentage did she see that had actually ruptured aneurysm? Because we're always worried, oh, the aneurysm will rupture. Oh, the aneurysm is too big, it's going to rupture. But
I'll say what Dr. David Holmes told Alkuri to go and make a good review. So I'll take your question. When I see her, I'll probably send it to her, but I'll give it to one of the fellows to maybe investigate it. Because this is, I mean, the idea of research. All of us, you know, we find challenging questions on day in, day out. But as you earlier mentioned, we only would see what we are looking for. But there are a lot more unanswered questions the more we deal with patients than actually having answers. So you're right. I mean, I'm sure a significant number. We don't know what is a significant number, and but sure we are missing.
Because I mean, up to what size do we not worry, and after what size do we start to worry?
So they say giant aneurysm is, as presented in both previous speakers, giant aneurysm is described as anything more than 20 millimeters or 4 times more than the size of the reference vessel.
Right.
So anything more than that is considered big and treatment is warranted, and of course something, yes, and it's always good, you have to have a protocol to follow these patients. So for example, if Kawasaki disease is presented and you are aware of it, you do serial echocardiographs, you follow them, even if they heal up, depending on their disease scoring, you basically lifelong CT scans, so that, but what time you institute treatment, this is really still, we don't have good answers for those, because you could take somebody to give them surgery and you bypass them, and then they develop a complication at the site or later on, but 5 years later the bypass is down, and then they have more aneurysms. Now they don't have a bypass, another thing to bypass to. So these are the challenges.
One quick question: do we have data long term comparing the results of graft stent versus coils? Because graft stents basically, they make us feel better, but as you mentioned, they have a higher stent thrombose rate. They have a target lesion failure of 28%.
Yes.
So
we are a little better. We only had graft masters, which you all know, that was two stainless steel, and in between there's a PTFE. Now we have the papillary stent, which is a little bit thinner, smaller. But again, still, we have to it's still high risk for stent thrombosis and lifelong stent thrombosis, not only initially and instant restenosis and all of these. With coils, the data on the coils, if you don't get a thrombus during the procedure and you actually isolate the vessel with a stent, then almost your risk of subsequent thrombosis is similar to a regular stent. And it could be still heightened if you did not completely close, but if you completely close and clotted and isolated off, you have better chance of having a new intima basically cover the stent. That's why some people suggest that maybe we should not do drug-eluting stents. We should do bare metal stents to allow more quicker new intimal formation over drug-eluting stent, delays that reaction. But we don't have, there is international registry, and actually review the data. There is an international registry for coronary artery aneurysm, and this is based in Spain, and they have reviewed, I think it was retrospective, started 2015 to 16, but they reviewed data going back to 2004, and they reported they published in the end of 2016. And in their data, about 500,000, little under 400 some thousand angiograms reviewed. They had 1,500 some cases, and those, almost half of them were treated with PCIs. And they had 27 cases that were treated with graft masters, and there are few of them underwent bypass surgery, not a large number, but the mortality 5 years down with both of them were very bad, not so good. Maybe stents were better than no treatment, and bypass, the event rate over 3 to 5 years was very high.
For both surgery. Surgery was a little bit higher, you said?
Surgery and PCI.
Yes, surgery you said was a little higher.
Yes.
Okay. Okay. دكتورة مرة and then دكتور خلاص.
Thank you.
استني اتكلم.
First question is, it is necessary every case of coronary aneurysm should be treated if patient with an angio and we have some coronary aneurysm and have no different symptom. Should we treat every case of coronary aneurysm?
Recommendation is individualize it. No, there is nothing that you individualize. You see what in this particular, where is the aneurysm, what is the risk, how much does it affect the patient, and a hard team discussion and options discussion with the patients from the available data that we have, that we cannot tell the patient that you have the aneurysm, you will be dead in 2 years unless I do a bypass or unless I do a PCI. We really don't have a clarity on that. That's why they say individualize.
The outcome of graft sent such cases, if there is what about the long-term use, the long-term results of the graft sent in these cases, and what about the old behavior in putting too lower of organ stents in the coronary aneurysm?
Yeah, so unless you have a registry where you put every coronary artery annular, and I think that's what should be done. They did it at the international level in Spain, they came, but I think this should be like when we use, for example, an Impella device, even though it's FDA approved, but every single Impella case goes to a registry, and that's how 2-3 years CVAD registry provides a lot of information about the use and the best practices around Impella. I think the same should be done for coronary artery aneurysm, especially when we talk about giant aneurysms. What's the surgical outcome? What's the PCI outcomes? What's the different details of the patient's presentation? And then we can probably come up with some good reviews on that. But at the current time, if they are in an ACS, if they have multi-vessel disease, you basically treat the culprit vessel and then take one step back and then make decisions about, you do the bypass, you do the PCI, you do the option of medical treatment, antithrombotics, aspirin plus Plavix.
This is my third question. What about the long-term misuse or the for-life decision to use anticoagulant or antiplatelet in such patients?
Of course, if this is a younger 20, 30-year-old, it's a tough decision. Because what's recommended, for example, is Kawasaki disease. With this patient would have presented, say, 2 years earlier. You don't have an acute MI, you don't have an occluded vessel, you have a giant aneurysm. The indication and the recommendation is to do aspirin and anticoagulation. The risk of anticoagulation is, of course, bleeding. And the risk of anticoagulation is warfarin and the daily checks. And aspirin, of course, has its own challenges, but you could substitute that with a P2Y12 inhibitor. They say with a lower risk aneurysm, for example, not a giant aneurysm, that you could consider a dual antiplatelet agent.
I have young lady, about 40s, and she presented with anterior anterior MI, total LED angio, and very hardly difficult to wire the LED, and abdominal course. So we ordered the LED. Unfortunately, huge aneurysm at the site of occlusion. Then the LED pass out TMT flow. I don't have graft stent in this situation. I put a drug stent. After 2 years, she went on antiplatelet and the low dose anticoagulant. Do you also have an angio patent stent? Do you, from your opinion, in such case, you should obliged to put the graft stent later or to pass or antiplatelet anticoagulant? What about what's your opinion in such case?
I think I would continue dual antiplatelet therapy forever. That's one case you have a stent graft all along this course. Late stent thrombosis, we've seen it. Anytime you put a stent graft, that cases that we just showed, I mean, they are more likely to not to get endothelialized. That's why you want a lifelong antiplatelet agents. The anticoagulants depend on the aneurysm. I didn't talk about anything about surgery. I asked our cardiac surgeon, Dr. David Baker, when I had this presentation, I said, can you give me some idea how do you guys handle coronary aneurysm? He says, it's a nightmare for us because mostly they are proximal, left main, LID, and we can't reach them, and you do put bypasses from competitive flow. Marsupialization, not a very good idea with interposition grafting, so yeah, they have to do ligation and bypassing. Sometimes in younger people, they may not mature up, and so it's a challenge.
Thank you very much. We can talk for hours. We enjoyed it. We have to move on, unfortunately. Now, thank you very much. It gives me a great deal of pleasure to introduce Professor Muhammad Arabi, who will give us his presentation on the role of immunosuppressive anti-inflammatory agents and anticoagulants in the management of coronary vasculitis. Is it beneficial? احنا اتكلمنا لحد دلوقتي على جرافت وكورس. طيب هل هي دي الأسلحة الوحيدة المتاحة؟ دكتور عرابي هيجاوب على السؤال ده دلوقتي.
Actually, the medical management of the aneurysms in the context of coronary vasculitis will entail the discussion of two major categories of pharmacotherapies. The immunosuppressive anti-inflammatory agents and the antithrombotic agents. During my presentation, I will skip some of the repeated slides because of repetition. This is what facts we have with coronary vasculitis. Coronary vasculitis for sure is rare. It has rare incidence. It has a diverse pathophysiology, unclear pathophysiology, and this makes the therapeutic and treatment decision is very difficult. It has the variable clinical presentation that is usually overshadowed by the systemic manifestation of vasculitis, fever, weight loss, rashes, arthritis, lymphadenopathy, and this is actually what makes me a little skeptical about the diagnosis that had been made in our case scenario as a Kawasaki, because it lacks all of these systemic manifestation, which is universal, particularly if we are talking about Kawasaki. It is a disease with high morbidity and mortality, where early treatment actually, as we see by immunosuppressive and anti-inflammatory agents, may make a difference. Unfortunately, we don't have randomized clinical data to guide us in the investigational and the therapeutic algorithms of these patients. And we don't have clear-cut guidelines directing our decisions in these situations. Medical treatment involves, as I said, immunosuppressive agents only in the acute active phase of these diseases. But in the late complicated phase of the cases, like the case that we have, immunosuppressive agents actually have a very questionable role in halting and preventing the progression of the disease. And here will come the treatment of the sequelae, like the use of antithrombotic agents, the use of interventional direction in such situations. Vasculitis, as we have heard, is actually classified according to the vessel size, large, medium, and small, and furthermore according to whether it is primary or a secondary to another disease process. Coronary arteries, as a medium-sized arteries, actually are involved in the medium-sized and large-sized vasculitis, namely Takayasu, giant cell arthritis, polyarthritis nodosa, and the Kawasaki disease, and very rarely involved in small vessel vasculitis. And the pathogenesis of coronary vasculitis is characterized mainly by immune-mediated inflammation, autoantibody-dependent reactions, and the inflammatory cytokine activation. It looks plausible that the use of immunosuppressive agents and anti-inflammatory agents in such a situation will be helpful and will be the cornerstone for treatment. As I have said, we have no randomized controlled trials. All we have case series. We have small descriptive studies, but we don't have randomized studies. But all the data is showing that using the immunosuppressive anti-inflammatory agents in the acute phase of these diseases will reduce the burden of vascular inflammation and reduce the long-term sequelae of these disorders. In Kawasaki disease, intravenous immunoglobulins, corticosteroids, and antiplatelets may have a role during the acute phase. In post-Takayasu and giant cell arthritis, steroids and interleukin-6 inhibitors have been shown to reduce the burden of arterial inflammation and long-term sequelae of this disease. In polyarthritis nodosa, cyclophosphamide in addition to corticosteroids has been shown to have an effect on the burden of the disease process and the long-term sequelae of the disease. But in our case, the question actually is immunosuppressive agents in such like patients where he came in the late, inactive, complicated phase of the disease will have an effect on the acute and long-term outcome. I am questioning this actually in such like a situation. If we are talking about Kawasaki, it is a disease of childhood, and mostly it is a missed early illness during the childhood. If the patient is not memorizing this prominent history of febrile illness, conjunctivitis, arthritis, skin rashes, mostly it has a very fulminant clinical presentation that cannot be missed. But if it has been missed, I am again questioning the rule of starting immunosuppressive agents at this complicated stage. It is not an active stage. Even the inflammatory markers, ESR and C-reactive proteins is borderline elevated, which may be even accepted in the context of acute STEMI as acute phase reactants. It is not a marker of it. In such like situations, if I have an active vasculitis, I will expect ESR over 100, CRB hundreds, so it is not an active. So I am questioning the role of starting the immunosuppressive agent at this late inactive complicated stage, even if you diagnose it as a Kawasaki disease. The other option of the pathology also involves coronary stenosis, thrombosis, aneurysm. I think that antithrombotic pharmacotherapy is needed in such situation and is crucial. I will skip this. This is a repetition from the other study. And besides the surgical and interventional percutaneous treatment of coronary aneurysm, for sure, medical treatment has a role in the management of this patient for the prevention of the deleterious sequelae, thrombosis and embolization, and the anticoagulants and antithrombotics for sure will play a role in the management of this patient. And this is an area actually that we don't have a consensus, and there is a lot of controversy, a lot of debates about the best cocktails to be used in such a situation. But this is a summary of the available literature that the role of antithrombotics, whether anticoagulant or antiplatelets, will be defined according to factors like the aneurysm size, particularly if it is more than 8 millimeter, the presence of abnormal flow, slow flow, the presence of aneurysm thrombosis, the clinical presentation of the patient. For sure, if I am dealing with an acute coronary syndrome patient, my approach will be different from a patient with asymptomatic or even presence with chronic stable angina. And overall, weighing the risk of starting antithrombotics versus the bleeding profile risk of the patients will make a difference in choosing the best cocktail for each specific patients. This is the summary of the available literature. Unfortunately, we don't have clear-cut specific guidelines for directing our practice regarding the cocktail of antithrombotics in such like situation, but this is the consensus among the available literature. If it is an incidental, asymptomatic small aneurysm, you can just continue with single antiplatelet agents. If it is asymptomatic giant aneurysm, and by giant aneurysm there is a different cut of values for the definition of giants, but as a general consensus it's more 10, 20, and there is in thrombotic aneurysm, anticoagulation is for sure needed in such like situations, even if the patient is asymptomatic. In patients presenting with acute coronary events, combined long-term antiplatelets and anticoagulants for sure are indicated. So other therapies like AC inhibitor and statins, through its pleiotropic effect, even in the absence of underlying atherosclerotic etiology, may have a potential role in slowing the progression of vasculitic aneurysm and preventing its rupture. For sure, anti-anginal and vasodilator drugs are harmful in such situation. Shouldn't be used in the presence of ectasia and in the presence of coronary aneurysms. So in our case, I think he is presenting in a very high thrombotic risk situation and in a relatively low bleeding risk profile. He is young. So starting triple antithrombotic therapy, combining dual antiplatelets and one of the NUAX is strongly indicated for at least 3 months. Dual antithrombotics, clopidogrel and one of the DUAX should be continued for 1 year. And for sure, anticoagulation for those DUAX should be continued indefinitely in such situation. Besides this, ACE and statins through its pleiotropic effect should be started and continued in such situation. And thank you very much.
Thank you very much. A very important presentation. السلايد اللي انت قلته around regarding التريتمنت وانه لما يبقى more than 10 اللي هو الاورال انتيكواجولانت يعني less than 10 millimeter size of the aneurysm, a single antiplatelet agent.
Yes.
Thank you very much.
دكتور دكتور محمد لطيف اخر توك 3 دقائق مش 5 دقائق، احنا الساعه 6 اصلا. اتفضل.
Thank you. I'm just going to wrap up the case and what we have seen with this. Actually, I want my presentation back, please. That's the only slide that the patient underwent CABG with aneurysmal clamping, okay, with saphenous vein grafting. The idea of this session and the idea of this case is to raise up questions about the debatable issues that we have already discussed throughout the session. The role of steroid therapy, that's a very good question, because is it an active vasculitis or chronic vasculitis? And that was a question and a matter of debate between us and the rheumatology department, and they decided at the end of the day that we cannot say definitely that is a chronic vasculitis and this is a complication and what the cause of the MI at this precise time. So we decided to go through steroid therapy. That's the answer to the first question. The second question is there is whether to put a graft stent or to do an aneurysmectomy. But our decision was to do an emergent surgery due to the large vasculitis that cannot be treated with graft stenting. It's not practical at this situation. Besides the dilemmas of passing a wire through this giant aneurysm, it would be a very difficult and challenging situation. The role of anticoagulation, and that's the other question we had to answer with a lack of evidence. But in such situations, we decide with such big thrombus in the RCA, the decision was to give the patient the full antithrombotic and anticoagulant medications. And the question is now for how long? We should give a 30-year-old patient either to give him a lifelong antithrombotic. Yes, we are going to give him a lifelong antiplatelet, but are we going to give him a lifelong anticoagulation? And that's the third question we needed to raise in this case scenario. And thank you for your attention.